Now let's begin with chronic kidney disease. We'll discuss definition, risk factors, etiology, clinical findings, diagnosis, and management of chronic kidney disease. Chronic kidney disease is defined as a sustained decline in glomerular filtration rate and/or 3 months or more of persistent accumulation of metabolites, electrolyte imbalances, and acid-base imbalances. Estimated glomerular filtration rate is less than 60. Here, all structural components of the kidney are damaged, resulting in end-stage renal disease. Risk factors leading to chronic kidney disease include hypertension, diabetes, and advanced age. Obesity, smoking, and alcohol may be risk factors as well. The presence of family history or acute kidney injury can also predispose the patient to CKD. Let's take a look at some causes of CKD. These include hypertension, nephropathy, diabetic nephropathy, glomerulonephritis, polycystic kidney disease, amyloidosis, and certain drugs. Clinical features can be absent in early stages. If symptomatic, they can present with uremic symptoms due to decreased clearance of urea from the blood. Symptoms include nausea, vomiting, encephalopathy, asterixis, pericarditis, pleuritis, bleeding due to platelet dysfunction, and infections due to leukocyte dysfunction. Other features include sodium water retention, which is evident by peripheral edema, pulmonary edema, and hypertension. Diagnosis is confirmed with laboratory investigations. There is increased blood urea nitrogen and creatinine due to impairment of renal clearance. Metabolic acidosis ensues as kidney is not able to remove excess hydrogen ions. Similarly, there are electrolyte imbalances such as hyperkalemia and hyperphosphatemia due to lack of excretion of potassium and phosphate, respectively. Hypocalcemia results from hyperphosphatemia and from decreased calcium reabsorption in renal tubules. The decreased reabsorption is due to the defect in vitamin D production. Recall that alpha-1 hydroxylase enzyme, which has a major role in vitamin D activation, is decreased when the kidney is damaged. Urine analysis shows proteinuria and waxy casts. Renal ultrasonography is done to identify any underlying causes. For example, cysts can be found in cases of polycystic kidney disease. If the cause is still not identified yet, then renal biopsy is considered. In this renal ultrasound image, we can appreciate the cysts as hypoechoic structures. This is suggestive of polycystic kidney disease. Management is started with supportive measures. Firstly, we should avoid using nephrotoxic drugs like NSAIDs and aminoglycosides. Sodium and phosphorus consumption should be restricted. Frequent adjustment of potassium through diet and medications should be made, and vitamin D supplementation is advised. Blood pressure control is necessary. Thus, it should be below 130/80 with the use of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. Statins are also started if there is associated hyperlipidemia and diabetes. Dialysis is required if supportive management fails. We will continue this in detail at the end of this lecture. Kidney transplantation is the end resort for end-stage kidney disease. Complications of chronic kidney disease are widespread. First and foremost is end-stage renal disease where literally the kidney shuts down. Another common complication is anemia of chronic disease, which can be managed by providing erythropoietin. Secondary hyperparathyroidism is another complication. It is an adaptive response of parathyroid gland in response to reduced calcium reabsorption in the kidney and resultant hypocalcemia. Chronic kidney disease patients are also at increased risk of cardiovascular accidents such as coronary artery disease and stroke. Other complication includes malnutrition and developmental delay. Let's finish off this lecture by discussing dialysis. Simply, dialysis is a therapy used to get rid of the metabolites and toxic materials from the body when the kidney is not able to do so. There are two types, hemodialysis and peritoneal dialysis. In cases of hemodialysis, an arteriovenous fistula is created. Blood is allowed to flow through a machine where molecules diffuse through a semi-permeable membrane and unwanted metabolic waste or toxins are removed. It is widely used for the management of chronic kidney disease. In case of peritoneal dialysis, process is similar, but peritoneum is used as a semi-permeable membrane, and it is limited only to adherent patients due to its complexity. Here's an illustration on hemodialysis. We'll not go into too much detail. It is sufficient to know that an arteriovenous fistula is usually created for long-term hemodialysis. This means that we create an anastomosis of an artery, commonly the radial artery, and a vein, commonly the cephalic vein in the arm. The blood waste products diffuse through semi-permeable membrane in the dialyser. Here is another illustration showing peritoneal dialysis. In this case, the peritoneal membrane of the patient acts as a semi-permeable membrane through which the blood waste products diffuse. Indications of dialysis is very important to know, and they're listed here. pH less than 7.1 is refractory to medical therapy. Serum potassium level of more than 6.5, which is refractory to medical therapy. Similarly, hyperkalemia with electrocardiogram changes. fluid overload, which is refractory to diuretics. Moreover, patients with symptomatic uremia requires dialysis. And also patients with ingestion of methanol, ethylene glycol, and drugs like lithium salicylate, carbamazepine, and sodium valproate. Complications of dialysis depends upon the type of dialysis. Hemodialysis can cause hypotension and a syndrome known as dialysis disequilibrium. It's an acute cerebral edema due to rapid loss of osmotically active substances like urea, leading to nausea, vomiting, confusion, and seizures. Whereas peritoneal dialysis has increased risk of peritoneal infections and metabolic disturbances. Let's end our lecture with a board-style question. A 75-year-old man presents to the emergency department due to progressively worsening shortness of breath for the past year. His past medical history includes poorly controlled chronic kidney disease due to diabetic glomerulonephropathy. He takes aspirin, 81 milligrams daily. His vital signs are significant for a blood pressure of 170/95 and a heart rate of 50. The physical exam reveals periorbital and pretibial 3+ pitting edema. Long auscultation shows end inspiratory crackles. His laboratory findings are significant for a serum potassium of 7, pH of 7.3, bicarbonate of 20, and PaCO2 of 32. ECG shows third-degree AV block, the finding that was absent 1 week ago. Which of the following is an indication for initiating dialysis in this patient? A. Acid-base disturbance. B. Electrolyte imbalance. C. Medication. Or D. Volume overload. The elderly man presents with progressively worsening shortness of breath for the past year. His past medical history includes poorly controlled chronic kidney disease due to diabetic glomerulonephropathy. He takes aspirin, 81 milligrams daily. His vital signs are significant for hypertension with a blood pressure of 170/95 and tachycardia with the heart rate of 50 beats per minute. Physical exam reveals periorbital and pretibial 3+ pitting edema. Long auscultation shows end inspiratory crackles. These latter findings suggest volume overload. He also has hyperkalemia with potassium of 7 and a mild compensated metabolic acidosis. Now the question asks what the indication for initiating dialysis is in this patient. He has all 4 factors mentioned in the option list, but electrolyte imbalance is the one that prompts urgent dialysis. This is because his potassium level is more than 6.5 and his hyperkalemia is symptomatic given a new onset third-degree AV block. So the correct answer is option B. Here is a slide reminding us of indications of dialysis. Pause the video and take a moment to consider this slide once again. Let's discuss why other options are incorrect. Option A is incorrect because metabolic acidosis is an indication for urgent dialysis only if pH is less than 7.1 and is refractory to medical therapy. This patient's pH is 7.3. Option C is incorrect because although aspirin toxicity requires dialysis, this patient takes only 81 milligrams of aspirin daily. Therefore, he is unlikely to have salicylate toxicity given the low dose of medication. Finally, option D is incorrect because volume overload is an indication for dialysis only when it is refractory to diuretics. Diuretics have not been used in this patient yet, so volume overload cannot be an indication at this point. And that concludes our lecture on renal failure.